So the FEDORA trial, relatively recently published in the British Journal of Anaesthesia, actually completed a few years ago, but there are some twists in the story here. It is a trial out of Spain. The title is The Effect of Goal-Directed Haemodynamic Therapy on Postoperative Complications in Low to Moderate Risk Patients, a Multicentre Randomised Controlled Trial, FEDORA. So making all the right noises, I'm privileged to be a co-author on the trial. And this is the editor's key points. 2 key conclusions. Haemodynamic optimization reduced complications and hospital length of stay in low to moderate risk patients having major abdominal surgery with no effect on mortality, and goal-directed haemodynamic therapy can be beneficial even in low to moderate risk patients. Now, the British Journal of Anaesthesia, and I said I've declared a conflict here, I'm on the editorial board, is the highest impact anaesthesia in the journal now. It trumped anesthesiology relatively recently, has maintained that pole position. But when you have a trial of over 400 patients, it's multi-center, randomized, controlled, and you have those conclusions, you're kind of a little bit suspicious when it's not in JAMA or the New England Journal of Medicine. Because I'll show you a smaller trial in a moment that's in JAMA, which has similar types of results. Now, there's a couple of possible reasons for that. One of it is, this is really pretty boring at this stage, because we now have completed, or there has been completed, according to the latest Cochrane meta-analysis preparation, 70 prospective randomized controlled trials, 70. And every time it's re-meta-analyzed, you come up with exactly that result again. So you're just reinforcing what the meta-analysis does. And if you want a definitive trial, absolutely definitive trial, which in these complex interventions can almost never happen, the power calculations are pushing up to 4,000-5,000 patients. So this trial reinforced, large trial, independently statistically significant, reinforced what the meta-analysis told us to expect. So you can have your own views on how you judge that. Now, very important point about this trial is it's not a goal-directed fluid optimization trial. So the trial that I originally did, an Oesophageal Doppler guided trial, was to use stroke volume measurements using esophageal Doppler and then give boluses of fluid to push patients up the so-called Frank-Starling curve. And many of the trials to date have been goal-directed fluid management trials, where they have tried to optimize or maximize, and we can debate that later, stroke volume, and then they've stopped when it comes to the other parts of hemodynamic management. More recently, we've talked about goal-directed fluid restriction, so the least amount of fluid required to produce and maintain central euvolemia. Now, we mentioned at the beginning that a lot of attention has been drawn recently to blood pressure. So we had an excellent presentation earlier from Andrea Kurtz on behalf of her colleagues at the Cleveland Clinic, and much of the work there has come out to say even relatively transient periods of intraoperative hypotension can be associated with adverse outcomes. So that then switches us into this trial. I'll loop back to FEDORA in a moment to say why it's different. This is the IMPRESS trial, published in JAMA. Sol Aronson and myself wrote an editorial that accompanied it. It comes from Emmanuel Foutier and colleagues, so it's a French trial, who've addressed this issue of if you individualize blood pressure management intraoperatively, and in patients who are deemed to be possibly higher risk of hypotension, you give them a norepinephrine infusion to maintain a slightly higher head of pressure, does it make a difference to outcome? This is a pretty small trial. No, it's an excellent trial, but everyone's discussed the fact that this is probably, if anything, a pilot trial, because it's less than 300. So it can't be big enough to give you an answer to this question. It can only be of a size sufficient to say this is a question that's definitively worth asking. There's a relatively subtle difference in blood pressure over time. It's only a few millimeters of mercury. The intervention, the norepinephrine infusion, produces a separation in the target variable, which is the blood pressure. There is a very dramatic difference in the composite outcome variable they chose. So that's very compelling to say, intuitively you'd expect that to happen. That's really interesting. We should probably continue to pursue this. Now, a really important thing to note, embedded in the appendices, is this is not just a use of vasopressor trial. It is a volume, then vasopressor trial. So all patients apparently had cardiac output measurement, because it says in the paper that's a national standard in France according to national guidelines. And all patients, having had cardiac output measured, received boluses of fluid to a maximum of 500 mils to increase their stroke volume until they'd reached the maximum. So they tuned them up a little bit first, mainly only 250 mils, maybe 500 mils, and then they randomized the patient. So this is a trial of cardiac output measurement, of stroke volume correction, and therefore possibly avoiding any degree of hypovolemia before you start the vasopressor, and then starting the vasopressor, which according to the appendix is a larger volume infusion of relatively dilute norepinephrine delivered via peripheral vein. So there's lots of little things to read in here. That means that can be quite broadly applied, but what it wasn't was giving hits of a vasopressor to a patient who may be hypovolemic without cardiac output monitoring. It's cardiac output monitoring plus volume correction plus an infusion of norepinephrine, which is not just an alpha agonist, it's also a beta agonist. So lots of variables that one can discuss in here. Back to the FEDORA trial, is what we're here to discuss. As I said, 420 patient multicentre RCT. Here's the fuller box of editor's key points. Starts off by saying whether goal-directed haemodynamic therapy improves post-operative outcome is unclear. So despite the meta-analyses, that's still the primary conclusion. The second thing is really important. The effect of esophageal Doppler cardiac output monitor guided haemodynamic therapy was compared with standard of care. This is a trial of the esophageal Doppler to see if that can be used to improve outcome. Now, we're heavily conflicted at UCLH in discussing the esophageal Doppler because it's been our house technology for as long as I can remember. But we also use other technologies. But in using this technology, what we've recognized is it is a precision tool. It measures velocity directly. You're not deriving anything. You may do something with that number. And I think everyone accepts the fact that it is the most precise tool. So everything else that we use, which may have greater utility for user-friendliness, is a sort of wannabe technology compared to that as a precision tool. Now, with precision comes more difficulty in use. So there are the focusing issues, the training issues, etc., etc. But one of the great debates will be about this trial is why do the Doppler trials continue to seem to verify the fact that there's an improved outcome in numbers that are well below those that other technologies seem to require? And that will be an ongoing debate until the bigger trials are completed. Does the precision mean that you're more likely to produce the effect you're looking for? As I said, it's not a fluid optimization trial. It's a hemodynamic optimization or goal-directed hemodynamic management trial. So by default, it uses the same algorithm that was recommended by the POCI group. In other words, is there a clinical problem? What do you think is causing the problem? Measure your hemodynamic variables, your cardiac output, stroke volume, and then use your brain is the most important thing. And when you've used your brain, ask the question, is if you think there's a deficit, does the patient need volume, i.e. preload? Do they need a vasoconstrictor or a dilator, or do they need increased contractility from their heart? And that is what the FEDORA algorithm went for. They moved away from just stroke volume optimization with fluid to make it a more complex algorithm. So the primary intervention, in this trial, only the intervention group is having cardiac output measured, so it's different to the IMPRESS trial from that perspective. Measure stroke volume, cardiac index, and mean arterial pressure. They're working principally off those three variables. Give fluid at 250 mils. And I made the point yesterday, the principal fluid they gave was a crystalloid. And after the first two boluses, the mandatory colloid that was then used for all subsequent optimization was a 6% hydroxyethyl starch. The next thing that's important in the study is, as we said, it's trimodal. So if the stroke volume correction produces what's deemed to be an adequate MAP, i.e. over 65, and an adequate index, which is over 2.5, do nothing. If the MAP's inadequate but the index is okay, give a vasopressor. And it looks as though about 20% of patients needed a vasopressor. If the cardiac index is inadequate, give an inotrope, and almost no patient required an inotrope. So it's predominantly a fix the volume, stroke volume, add the pressor, in all patients keep the MAP above 65. So it's another interesting contribution to that whole discussion. The demographics, Of note, there is imbalance in the two groups, but by my reading, the imbalance is such that the majority of, if you want to call it, sicker patients are, if anything, in the goal-directed group. So ASA grade 3, for example, 35% in the goal-directed compared to 19% in the control. I'm not making any big deal of this, but if you do say there's imbalance in the groups, the imbalance is such that possibly the sicker patients are in the goal-directed group. This was referred to yesterday. This has become a recurring theme in these trials, is when you look at the end of the trial and the therapeutic interventions, it's now very common to find that there's no difference in the amount of fluid or the amount of drugs given. So goal-directed versus control, estimated blood loss, possibly a little bit higher in control. There's really no meaningful difference in the amount of fluids, perhaps a little bit higher in the postoperative crystalloids, but none of them anywhere near statistically significant. Outcome variables now, time to tolerance of food, that's been a recurring theme in the literature, time to ambulation, length of hospital stay, intensive care unit stays, all in favour of the goal-directed group. Now, some other discussion points in here. For those of you who've done these trials, they're very, very difficult to eliminate all biases. So in the paper, they discuss the fact that performance bias is always a risk. No matter how much you try and blind the intervention, if there's a sort of awareness that people are in a certain group, there's always a possibility that people are going to feed them earlier and get them out of bed earlier. So they discuss that in the paper. But it's unlikely that that's a dominant feature through all of the trials that's been done to date. So the overall result's in favour of it. It's dominated by the GI patients. 304 of the patients are gastrointestinal patients. That appears to be independently statistically significant. The urology is bang on the line of unity with large confidence. The laparoscopic patients make up half the overall population, and that is independently statistically significant in favour of the intervention. And there's been a lot of debate about that already. Obviously, it might just be an error because it's relatively small. It's only a few hundred patients, bigger than almost every other trial that's been done before. But the fluid-only management trials may not have been enough for the laparoscopic patient. It may be the addition of the vasoactive agents that makes the difference in those. The major things that have come out of the other trials and are strong in the meta-analyses are less acute kidney injury, which it is statistically significantly less acute kidney injury, less pulmonary complications, which you'd expect with better fluid management possibly, and fewer infectious complications. And this fewer infectious complications has not only come through fairly strongly in this goal-directed literature, it's also there in the IMPRESS trial, the blood pressure one, which is a little bit tantalizing as well. So, to conclude, hemodynamic optimization reduces complications and hospital length of stay in low to moderate risk patients having major abdominal surgery. Thank you very much for listening. Enjoy reading it.